Professor, are you talking?
I'm here.
Okay, sorry, I forgot to unmute. Okay, I'll start over. So this is chapter 42, adrenal disorders. So there are three major secreted by the three S's. So we have the salt, sugar, and salt hormones. The sex hormone, sorry. The salt hormone, of course, is the mineralocorticoid, aldosterone. Then we have the sugar hormone, which is your glucocorticoid, which is cortisol. And then finally, your sex hormones, androgens, and estrogens. Now, as far as the sex hormone is concerned, this will only affect females because the sex hormones in the male patient is in the is in the testicles. So when the problem occurs in male patients, there won't be a problem with the sex hormones. But the really life-threatening problems here occur with cortisol and aldosterone problems. So there are two problems here. Either you'll have a overproduction of the three hormones, or you have a under secretion of the three hormones. Either way, there will be problems. Let's begin. Let's review first. This will help us understand and imagine the signs and symptoms, and therefore the treatment for each problem. So your sugar hormone is cortisol. The purpose is, of course, to manage blood sugar levels. So it will have control over carbohydrate, fat, and protein metabolism. So you saw this in DKA last semester. So your body can produce sugar from all these three stores. So it can take glycogen apart, turn it into glucose from the liver, so that's carbohydrate. It can turn fat deposits, turn them into sugar, that's ketogenesis, and then we have gluconeogenesis when you break down protein. So that's how the body produces sugar. So you can imagine if you're at one, if your cortisol is low, so your sugar is low. In at the other extreme, cortisol is very high, sugar is very high. And with aldosterone, aldosterone affects two things. It acts on sodium and also water reabsorption. So what will happen if it is low? You're losing sodium, you're losing water. So your blood volume drops, blood pressure drops. On the other hand, if you have too much of it, then you'll have high sodium and high water, increasing blood volume, increasing blood pressure. But also remember the sodium-potassium pump relationship. So therefore, in one end, if your sodium is low, that means potassium is high. And on the other end, since your sodium is high, potassium will be low. Any questions so far? All right, let's discuss the two disorders now. Let's start with insufficiency first. So you don't have enough. The disease is called Addison's disease or primary insufficiency. They say primary because this is an adrenal problem. You can also have adrenal insufficiency, which is secondary, this time caused by a pituitary problem. So let's review. These are endocrine glands that we're talking about. When we say primary endocrine disorder, we're talking about the individual endocrine gland, meaning it's either the remember from hypo and hyperthyroidism last semester? So that was an endocrine gland. If it's primary, that means the problem, the defect is in the organ itself. It can be secondary if the problem is from the master gland. Because remember, the pituitary gland controls all these glands. So it will be secondary if the problem isn't that endocrine gland itself, but rather the master gland, which is defective. So the master gland, which is the pituitary gland, can either be hyper or hypoactive, which will affect all other glands under its control. Are you with me so far?
Yes.
Okay, so let's talk about Addison's disease. Addison's is primary insufficiency. The problem here is in the adrenal gland. The number one problem here is usually caused by a tumor. So you have a tumor growing in the adrenal cortex. Again, the adrenal cortex produces three hormones, major hormones, salt, sugar, and sex hormones. So that's aldosterone, cortisol, and your androgens in the female, and estrogen. So let's differentiate because we will have another problem later in pheochromocytoma, which is now a problem in the medulla. The medulla part of the adrenal gland is the part that releases your catecholamines, which are your fight and flight hormones, epinephrine and norepinephrine. So these are two separate sections of the adrenal gland. So imagine a patient who has low cortisol, low aldosterone, low estrogen, or low androgens. What will they present like? Your sugar level will be,
High.
again, this is insufficiency first. So you're
Very
low
low.
in your salt, sugar, and sex hormones. Salt hormones, again, is the aldosterone. Sugar is cortisol. And then you have your sex hormones. So in adrenal insufficiency, you are low in all three: salt, sugar, and sex hormones. So what will be the blood sugar level here?
Low.
Low.
It'll be low. The patient will have hypoglycemia most of the time. What about aldosterone? If the aldosterone is low, what will be the patient's blood pressure?
Low. Low.
Low.
Very low.
What will be the patient's blood volume or fluid volume?
Low.
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 Okay, so far we've agreed on hypoglycemia, hypovolemia, and hypotension. Now let's go now to the electrolyte problems, because aldosterone controls sodium. So if you are low in aldosterone, what will happen to your sodium level?
Going to be low. Low.
Low.
Low.
What will happen to your potassium level?
Going to be high.
High.
Very
high.
All right, so we're agreeing, right? Okay. However, there's another problem here. Can you read this section, Gladys?
Because melanocyte stimulating hormone and ACTH progenitor ancestor hormone, there is an associated increase in secretion of MSH, leading to a darkened bronzed hyperpigmentation that accompanies the increased secretion of ACTH.
All right. So this is because they have inverse relationship with cortisol. So if your cortisol and aldosterone levels fall, the melanocyte stimulating hormone and the adrenocorticotropic hormone are going to increase. So this is the reason for the darkening of the skin color of these patients. So that will account for the bronzed appearance of the skin. So the symptoms here, indirectly resulting from the low levels of cortisol and aldosterone, are the following. So your patient has hypoglycemia, less energy, weakness. They have less blood volume, weight loss, fatigue because of hypotension, nausea, vomiting, because organs here will have less blood flow. So that will account for your abdominal pain and nausea and gastroenteritis. The emotional lability here is because of the cortisol, and of course your low female hormones, you know, estrogen's low, so you'll have emotional lability there. And we have the hyperpigmentation, and because you have less female hormones here, so you'll have decreased pubic and axillary hair, which is not so bad, right? Unless, you know, some patients don't like it that way. So here is the skin changes.
Yeah.
Obvious bronze colored appearance. Of course, compared to the patient's previous skin color, which is considerably dark. So here, there is a, we'll skip um, the test because there is a cortisol, or what we call steroid something, dexamethasone suppression test or something. That's the test they use. We won't test that because the doctor does that on his own. However, we will see lab results directly resulting from the Addison's disease, which again here you'll have cortisol will be decreased, glucose decreased, potassium increased, sodium decreased. This chart, they already compared both the so we'll go back to this chart later when we talk about Cushing's, which should be easy. I mean, they're all totally opposite. So here, low in one, high on the other. It's one or the other. To help you not make a mess out of the exam one, just stick with the hormone. Okay, so just think about what the hormone does. Talk about questions about physical findings and lab findings. On the test question, students typically get this confused, but again, the way you remember is just stick with the hormone. Okay, what hormone is the problem, and stay with what does the hormone do. So that will help you remember what the answers will be, what will be the resulting signs and symptoms. We won't test table 42-3. Again, those are not common tests, so we will use this one because this is what we will see on a day-to-day basis. So since you have a low or deficiency in the hormones, if you compare this to hypothyroidism, what do you think will be the treatment? So in hypothyroidism, which was another endocrine disorder, how did we treat hypothyroidism?
Hormonal treatment.
Okay, simply replace the hormone, right? We give the patient levothyroxine. So what do you think will be the treatment here? The patient is low on cortisol and low on aldosterone.
We are going to give them hormones.
All right,
So
exactly. Right. We will give the patient hormone replacement. So we will replace mineralocorticoids. We will replace glucocorticoids. So the patient will receive steroids here. So we have glucocorticoids, which is in the form of hydrocortisone. So that's Solucortef. And then, or they'll get dexamethasone or Decadron. And here, thank you for reading this, Miss Iggy.
one of the advantages of hydrocortisone is that it has both glucocorticoid and mineralocorticoid actions.
Okay, so this drug is 2-in-1. So it's both your glucocorticoid and your mineralocorticoid. So it has both actions on blood sugar levels as well as on sodium levels. Pretty much the same effect as aldosterone. So those are the mainstay replacement. For the problem related to hyperkalemia, because the patient has hyponatremia, right? Which means they will develop hyperkalemia. We already discussed the many options in treating hyperkalemia to lower potassium levels, namely insulin with dextrose. Then we had thiazide diuretics, or loop diuretics rather. And then we had calcium gluconate, or we can also have K-oxalate. K-oxalate is sodium polystyrene sulfonate. In day-to-day though, because the patient won't have extremely high potassium levels as long as they take the medications daily, K-Exalate will be okay with day-to-day. So they'll just simply take K-Exalate one or twice a day, because the goal is to have a bowel movement. So if one K-Exalate won't result in bowel movement, then they have to take a second dose, because that would be the um, fastest. I mean, the only way K-Exalate will remove potassium is through the GI tract. So no bowel movement and no potassium excretion. Complication. There is a life-threatening complication here known as adrenal crisis. When the patient experiences stressful events such as trauma, surgery, or infections, these are the most common. Trauma and surgery, we know that's stressful. And infections, yeah, you could go septic shock, and all the complications resulting from that. The stressful event, though, doesn't have to be only trauma, surgery, or infections. Is going to nursing school during COVID stressful?
Yes.
Yeah. Losing your job, being furloughed, because of the lockdown, is that stressful?
Absolutely.
Yeah, having kids around, having to be the teachers um, during this seemingly unending, no end in sight so far. It'll be here until December. This will be the setup. Is that stressful?
Absolutely.
Very.
Yeah. Okay, so we have no break from the family, right? We see them every day. We face each other. I'm sure the kids feel the same way about us.
Yeah.
So that is stressful. So any of these can trigger an acute adrenal insufficiency. So think of all those signs and symptoms we talked about happening at, at high levels all at the same time. So think about a patient who has hypoglycemia, hypotension, and hyperkalemia all at the same time. Will this patient still be conscious? Are you going to be awake if you have all those three problems?
Probably not.
No, you'll go unconscious. You'll pass out, right? So this is now severe hypovolemia and severe hypotension. And we're talking about severe hypoglycemia. Your sugar here will be under 40, so that's already mild to, no, that's already moderate to severe. Plus the hyperkalemia here, the potassium level is above 6. So we're talking 6.5, 6.8, or even 7. So each one of those are life-threatening. You can't really say, oh, yeah, the hypoglycemia is more life-threatening. No, all three are life-threatening episodes. So therefore, does the patient need to be hospitalized?
Yes.
Definitely. We'll discuss this here under surgical management later, because this is in preparation for, let's say, if we treat the other disorder. Remember in hypo and hyperthyroidism also that when we treated hypothyroidism, they could become hyperthyroid.
Yes.
And then also with hyperthyroidism, when we treated them, what happened to them?
It could be
They
hypo.
became hypothyroid. So it's exactly the same scenario here. So in adrenal insufficiency, while we were replacing them with the hormones with hydrocortisone, they could develop the other problem, which is called Cushing's syndrome. And then once we treat Cushing's disease, which is the opposite of this, just like in hyperthyroidism, so the patient with Cushing's, once treated, now develops Addison's disease and is now at risk for adrenal insufficiency. So either way, both patients will end up becoming Addison's disease. We'll move on and then I'll explain that. So here are your problems again. The emotional lability, that is again because of the low female hormones. So during an emergency, the patient will receive, again, the keep in mind the patient's unconscious. Nobody's awake if you have shock level blood pressure, um, moderate to severe hypoglycemia, and severe hyperkalemia. The patient is, if not already having cardiac arrest, um, because the blood pressure already caused decreased cardiac output in the first place, plus you add cardiac arrest to that, further dropping your cardiac output. So patient's not going to be awake. Plus, they don't have enough blood sugar for the brain, so the patient's unconscious. So all our management here will have to be IV. So let's look at the actions now. So this is during an acute adrenal crisis. The triggers, by the way, I'd like to remind you. So if the patient here already has Addison's and then experiences a severe stressful event like surgery, trauma, or they develop an infection, or let's say I break up with Giselle. Okay, I told Giselle a week ago. I don't know if she believed me, but I did tell her I'm not seeing her anymore.
Oh no.
I'm just kidding though. Okay, so you'll be okay.
Yeah, we all know you're kidding, Professor.
All right, yeah. So we're still on. Okay.
Okay.
You don't have to be, yeah. You don't need another stress like that. All right. So the patient here is unconscious, so everything will be IV. What will be the management? So management will be geared toward the severe hypotension, the severe hypoglycemia, and the severe hyperkalemia. So IV administration of fluids, it'll be saline, of course. Or if you want to hit two birds with one stone, give them dextrose in water because that's also isotonic. So you get increased blood pressure from that, increased blood volume, plus you give them sugar at the same time. So, two birds with one stone with using dextrose in water, 5% dextrose in water, D5W. And then we give corticosteroid, lots of it. So we can give bolus, Solicortef, and then we'll give them a continuous infusion of Solicortef or dexamethasone, and then we'll also give them additional, twice a day injections just to maintain blood pressure and sodium levels. And as far as the because you have hyponatremia, patient will now develop seizures, right? If the patient has severe hyponatremia. So institute seizure precautions and fall precautions because of the postural hypotension, or that's orthostatic hypotension once they, of course, return to consciousness. And then finally, hyperglycemia management will be the ones I mentioned earlier. They're not mentioned here anymore because they've been discussed in previous chapters. So namely, again, hyperkalemia management will be insulin with dextrose. We choose that first because that's the fastest way to shift potassium, remember? Because the Kxalate, which is sodium polystyrene sulfonate, will take 2 hours to work. So that's not going to drop your potassium anytime soon. So you need to shift it first using insulin with dextrose, IV, or calcium gluconate. And then we had the diuretics, loop diuretics, which will excrete potassium, but of course we won't be going after that as a first choice because remember, diuretics will also remove what besides potassium? Sodium and water. So the patient is already hypovolemic. So I don't think we'll go with the diuretic as a option for lowering the potassium in this particular episode. So it'll be still insulin with dextrose and then Kxalate. Day-to-day teaching now. So let's say the patient survives and then they go home. So they'll be taking the hormone replacements, correct? So they'll be on hydrocortisone daily, sometimes twice daily, depending on how the doctor writes it. We tell them to, what did we learn about in pharmacology or in previous semesters, you always told your patient never to stop steroids abruptly. What was the reason for that? Why should we always taper off steroids? Why can't we just stop it one day and be done with it? Why does your Medrol dose pack always look like that? So you open your Medrol dose pack, you have like 100 pills on the first day, and then second day it keeps dropping. Why is it like that?
Can't the patients go into crisis?
Okay, that is one of the reasons that could lead to acute adrenal insufficiency, which is adrenal crisis. So it should always be tapered. So can they stop it at any time? Because eventually you'll get sick at one point and you won't be able to take anything by mouth, including your pills. That's going to happen, right? So what should they do if that happens?
Contact their provider.
All right, call their doctor or go to the ER because they cannot stop the steroids. Any questions? That's it for adrenal insufficiency. All right, let's proceed with Cushing's. There are two. Come on. There are two forms here. We have Cushing's disease, which is primary Cushing's, and then we have Cushing syndrome, which is secondary. Now, if you remember on the last statement here in the teaching under Addison's disease, look at that last statement here. Over replacement can result in what? Weight gain and osteoporosis. This is actually symptoms of Cushing syndrome. So since the doses are adjusted constantly, plus our hormone needs change without us knowing it, meaning, for instance, if you're under stress, do you need more or less of the hormones, of the steroids?
More.
You need more because you are in more you are facing more stress. And in the same way, if you are more relaxed, nothing's going on, no problems, everything's good, your stress levels go down, do you need more or less of the hormones?
Less.
You need less.
Less.
So at some point there will be an imbalance which can lead to Cushing syndrome. The patient might go into overdose of the hormones, the steroid hormones, which will lead to Cushing syndrome. So this is why Cushing syndrome is not necessarily treatable, because Cushing syndrome can result from any condition wherein a patient has to take steroids. For instance, not only Addison's disease people will take steroids. We're talking about rheumatoid arthritis patients, COPD patients, asthma patients, lupus patients, multiple sclerosis, all other people with autoimmune disorders like Crohn's disease. So these are chronic conditions for which they have to take steroids. So you can't really treat Cushing syndrome per se. You can adjust the dose of the steroids so that you don't develop Cushing syndrome, but you see what I'm saying? You can't really cure Cushing syndrome. Meaning you'll go in and out of Cushing syndrome every time the hormones in your blood go too high. Does that make sense?
Yes.
Meaning you'll be at risk for Cushing syndrome for as long as you are taking the steroids. Is that clear?
Yes.
Okay. Cushing's disease, however, this is primary. So what are the causes of Cushing's disease? Just like Addison's disease, which was caused by a tumor growing in the adrenal cortex, this one is another tumor growing in also either in the adrenal cortex or a tumor in the pituitary gland. So that is both Cushing's disease. The simple treatment is you remove the tumor, surgically remove it, either from the pituitary gland or from the adrenal gland. However, after we remove the tumor, what happens to the patient? Do they still have Cushing's disease?
No,
No,
they
they
have
probably have
Cushing syndrome.
but they don't have,
probably have
but they are not
What do they have now? Because now you have no
Cushing
adrenal gland.
syndrome.
mm,
No, you lost your adrenal gland. There is nothing more to release salt, sugar, and sex hormones.
Addison's.
So
yeah.
Oh,
they have
Addison's.
added-
So
Yeah.
you
Now
release
you
the
develop
hormone.
Addison's. Okay, so this is again what I'm saying is it's exactly the same as what happened to the hyperthyroid patient. In
Mm,
hyperthyroidism, we treated the patient's thyroid, we gave them anti-thyroid medications, we gave them radiation, or we surgically removed the thyroid gland, and then they developed hypothyroidism. Exactly the same here. So we had Cushing's disease. The treatment will either be bilateral or unilateral removal of the adrenal glands. And so if you lose both adrenal glands, then you have Addison's disease now. Does that make sense?
yes.
Okay. So let's start with the, I said bilateral because of course, if only one adrenal gland is removed, do you have Addison's disease?
No,
You
because you
only
have not
lost one.
No.
No, you don't.
put the
No.
other.
Okay, so you still have another one. So maybe for a short while, maybe 1 to 2 years, you'll have those symptoms, but then the remaining adrenal cortex should compensate and then keep, catch up eventually, and then you'll be okay. You'll be back to normal. You don't have Addison's disease. Another problem with hypercortisolism, this time will be hyperaldosteronism. So this is not Cushing's disease because this one is another tumor, but only affects aldosterone. Okay, it doesn't affect the cortisol level or the sex hormones. Okay, this is a different problem, Con syndrome, which since this only affecting aldosterone, the patient will therefore have high sodium, high water volume in the blood. So they'll have hypernatremia, they'll have hypertension, like severe hypertension, and because they have higher sodium, they have lower potassium. Um, so these are your problems: severe hypertension and hypokalemia at the same time, and hypernatremia. Because the blood pressure is so high, this will put the patient at risk for strokes and even heart failure. The treatment for this is simply we remove the tumor, surgery again, and then they'll be as good as new. However, if we remove both adrenal glands in a patient with Con syndrome, of course, they will also develop Addison's disease as a result. Manifestations. So we'll go the other way now. So the patient has high salt, sugar, and sex hormones. This is what the patient will look like. Again, the sexual characteristic changes here will not be present in a male patient because why again?
Because it's in the testicles.
Because they
The
don't
sex hormones are where in the male?
in the testicles.
In the testicles. Okay, so this one, the sexual clinical manifestations will only appear in a female patient. So let's begin. So you have high salt, high sugar, and high sex hormones. High aldosterone will cause high sodium, high blood volume. So you'll have high blood pressure, fluid overload, edema as a result, and then you'll also have hypokalemia. So that's for the aldosterone. Now let's go to the cortisol. So cortisol is high, sugar is high. So you have hyperglycemia. However, what will happen to your, so if you have hyperglycemia, what will the body do to the excess sugar that you're making?
Going to produce insulin.
No, you will have a lot of too much sugar. Your body don't know what to do with the rest. So what will happen to the excess sugar?
It turns into fat, doesn't it?
All right. So the body turns it into fat, and so the fat will be deposited in your various parts of the body, usually in the abdomen or right here in the back of the neck. So you'll have a buffalo hump. You have the moon face, because this will be a combination of fat and edema. Um,
Enhance.
you'll also, because the abdomen will be stretched here because of fat accumulation plus fluid accumulation also, because the patient is in edema from head to toe, you'll have stretch marks here forming. Because now you have more fat compared to muscle, plus the hypokalemia that results because you have hypernatremia. So hypokalemia will decrease muscle strength. So the patient feels weak, therefore will stay in bed. That will lead to decreased muscle mass because they'll move less, and plus there will be more fat compared to muscle now. And this is, remember, a stress hormone, so there will also be increased gastric acid secretion. Increased gastric acid secretion impairs calcium absorption, so that will lead to osteoporosis, putting this patient at risk for fractures. So not a good combination here. They're weak because they have decreased muscle mass, putting them at risk for falls. Plus, when they do fall, they'll sustain a fracture for sure because of the osteoporosis. So that's not good either way. So now we'll skip the diagnostic test. We'll go to the remember the table here, table 42.2, giving the levels, which was under Addison's. I really don't want to go back there. So just refer back to this. That said, what will be the cortisol level for this patient?
Elevated.
High.
Gonna be
What would be the sodium?
High.
The potassium?
Low.
low.
Very good. All right. That's it. All right, so yeah, we don't need to go back there. Let's go to management now. Drug therapy we will skip because drug therapy is only used short term, and by short term, only in preparation for surgery, because the patient with Cushing's disease will need surgery in order to have a permanent treatment, unless the patient just wants to stay like this forever. I mean, their choice, but I don't think they'd want to. So they'll only be on medications, on drug therapy for a short period of time, only um, temporary, on a temporary basis. So what we're doing is we are preparing the patient for surgery. Now here comes surgery. What was one of the consequences if we remove one or worse, both adrenal glands here? What will the patient
Addison's.
develop? Addison's. Now, what was one of the triggers for adrenal crisis?
If they don't get the hormone.
A stressful event like trauma, surgery, infection. So, if this patient undergoes surgery, remember, the moment we remove the gland, there's no more steroid secretion, right? So is that equivalent to stopping the steroid abruptly?
Yes.
Yes, that's exactly what's going to happen. So we're expecting acute adrenal crisis to happen during surgery. So we're talking about shock, severe hypoglycemia, and severe hyperkalemia. Do you want that happening on a surgical table?
No.
No. So to prepare, we will have to give the patient steroids before, during, and especially after surgery to prevent the adrenal crisis from occurring, because the patient will develop Addison's the moment we cut off blood supply to those to the adrenal cortex and remove it. So that's the number one preparation, is give the patient steroids before, during, and forever after the surgery. Are you with me so far?
Yes.
Because the patient will develop Addison's after the surgery. Um, Here, hyperaldosteronism, I mentioned that it will also be surgical removal. So that's also here. So same thing, same post-op care, because again, the patient here in hyperaldosteronism or Con syndrome will lose one or both adrenal glands, right?
Yeah.
So they will also develop Addison's disease. Complications. If there was adrenal crisis in what we call this in Addison's disease, what do we call the emergency here in Cushing's disease? Because there has to be, right? We had an Addisonian crisis or adrenal insufficiency, acute adrenal insufficiency. What's the Cushing's disease crisis? Okay, please find out on your own. So let's continue with the complications post-op. So we know that the patient undergoing adrenalectomy is at risk for acute adrenal crisis. So we prepare again. So here are the preparations. We give corticosteroids before, during, and after the surgery. The patient, of course, will also receive supportive treatment because remember about the hyperacidity. So the patient will also receive um, PPIs um, to keep the gastric acids down. And then after the surgery, remember now you're dealing with a Addison's disease patient. The difference is again, if the patient only loses one adrenal gland, will they have Addison's disease forever?
No.
No, probably for again 1 to 2 years maybe. They'll have to be taking supplemental hormones until the remaining adrenal gland um, is able to compensate for the loss of the other one. So the symptomatic management here will be related to supporting, just like what we did earlier, so supporting perfusion, giving fluids to maintain blood pressure, giving um, blood glucose for the hypoglycemia, and then treating the hyperkalemia.
Would it be Cushing storm because it was like thyroid storm?
Similar to that. Only because
Isn't it that Con syndrome?
no, Con syndrome is hyperaldosteronism. It's a different disorder. Anyway, it's not mentioned here, so that's why I won't test it anyway.
Okay.
It didn't mention it. And then that's it. That's for your Addison's and Cushing's. Any question? So the patient after surgery now has Addison's disease, and that's a forever thing. So you're back to hormone replacement for life. Questions, future nurses? I know a few people had internet connections today. That was how I was yesterday. I was late for lab yesterday for that same reason. Internet keeps... We should get a refund, right, when that thing happens.
Yes.
Sure.
Anyway, all right, it's been nice, guys. Stay safe, wash your hands, and wipe from...
Professor,
Yes.
a question. The next quiz, which will be on Friday, it's going to be covering chapter 17, 57, and 42.
Yeah, post-op. And what was the other thing? Yeah, peptic ulcer, and then Addison's and
Adrenals.
Okay, thank you.
alrighty. Next week is the third quiz, and then after that is the exam. Okay, so prepare ahead.
Okay,
Thank you.
Alright.
Thank you.
Bye.
thank
Another
you.
thing, Professor, one question, sorry.
Yeah.
Since lab is canceled on Monday, do you still want us to submit for Monday or we submit for the following Monday?
You mean clinical?
Yeah.
Yeah. Nothing is due Monday, but of course, if you submit early, yeah, get it out of the way.
Okay.
Yeah.
Thank
But
you.
it's technically not due this Monday because it's a holiday.
Okay. Just double checking. Thank you.
Okay, boss.
Bye, Professor.
Thank you, Professor.
Bye.
Have a nice weekend.